Hello all, and welcome to first ever webinar with Manuthera. My name is Vili Rahkonen. I'm here with Mr. Kevin Cole, and today we're going to talk about Manuthera and also dysfunctions your patients may have in the thoracic section and with breathing. Good morning to our friends from Canada. I saw there was already a few of you online. Altogether, we got over 500 people to click the participate button, so hopefully many of you can join even live. I know that we all live in different time zones, so it can be difficult for all of you, so we're going to record this and also share the recording with you afterwards. I've heard one therapist call Manuthera the Rolls-Royce of treatment tables, and I believe him as well. It's very versatile table, but today we're going to focus on the thoracic section and maybe the cervical spine also a little bit. For the future webinars, I hope you give us also feedback and ideas on what we can focus on. There's a chat in YouTube that you can use for questions and ideas, and also if you want to, for instance, buy the table, or if you want to ask more questions, you can find my email in the description. Please send me email for any questions you may have. Also, for the further questions, further knowledge, if you want to learn more, please visit the Manuthera Learning Hub, the link also below. Now, I think it's time to give the microphone to Kevin, and please go ahead.
Thanks, Vidi. Hello, everybody. My name is Kevin Cole. I'm an osteopath. I work in my own clinic, in my own practice. I have a Manuthera table that I've been using since 2016 now, so about 4 or 5 years. And now today I'm going to tell you about how I do work on the thoracic spine. Now, there are many reasons why I would be interested in the thoracic spine of my patients. I see different patients in my clinic. Some of them have troubles with maybe the shoulder or the lower back, maybe pain in the thoracic area, maybe some problems correlated with breathing. Some people may have pain related to breathing. They are usually acute cases. So then they will seek for help for mobility and function in the thoracic spine. Sometimes they might come for another reason. Maybe it would be linked with breathing, with restriction for breathing. So maybe they might just feel that they don't get air in their lungs without any pain. So the pain wouldn't be the cause of the restriction, more about function. Now, it might be also that I will be interested in the thoracic spine if my patient have lumbar area pain, or maybe shoulder pain, or even cervical spine area. Now, for all these reasons, I will do an examination of the thoracic spine. And this is what we're going to have a look on today. So I will show you basically the different techniques I use to do an examination on the thoracic spine, also upper thoracic, and then the ribs. Now, keeping in mind that we also have other parts moving, and that other techniques we can use. So lumbar spine and cervical spine, for example, are some other topics we can go through in another webinar. Right, so the way I would start my examination, of course, with my patient standing, I would do some active movements, flexion, extension, and side bend and rotations. I would have a look at breathing patterns also. But for the thoracic spine itself, I would start with having the patient prone. I will open here. And what I'm going to do first is use the lateral side bend of the table here. Now, using this lever that you can see on that side, I can move also it from this side. I will free the movement into lateral side bend, And I will keep a good control here with the other hand. I will put my thumb on the lateral aspect of the spinosus process here on the spine, on the thoracic spine. My hand will stay on the spot, and with the other hand, I will just gently move the patient into sideband. Now my thumb here resist here a little, and what I'm aiming at is feeling, do I have some movement in the spine into lateral sideband here, right? So we'll look this way. I can start from pretty low in the thoracic spine and then go little by little upper here. Now I can feel I have some restriction in this area here. There. Then I would do the same from the other side to check for sideband into the left here. Here. All right. Now, once I've done that on the middle and low thoracic, I'll have a look at the upper thoracic. Basically, same principle. I will use sideband now of this part of the table. So I will open with this lever here. Yeah. And again, lateral side of the processus spinosus of the spine here. I can start from C7, just below C7, so T1 here into sideband and then go lower, or I can start lower and go higher. There. And again, I'm looking for restriction in passive range of motion. Here. Again, I would do this also on the other side. Now, in this case, I noticed that in the CT junction area, I have some restriction into sideband. And here, in this area. So about T4 area into sideband, now at least to the right side. Okay. So basically, sideband examination of the thoracic spine and upper thoracic with the patient prone. Now there's other ways I could do this. I could do this with my patient sitting, for example, and I could be standing behind my patient, holding the patient's elbow here and using my body movement to do this. Now the reason why I like to do this in this position, this way, is that it's very easy for the patient to be relaxed and to have a good movement still. The other reason is that depending on the size of the patient, then this allows me still, even if my patient is bigger than me, and I would not be able maybe to handle the patient as comfortably in a sitting position. Now this is a lot more comfortable in this position. Now once I've done this middle and lower thoracic and upper thoracic examination, I would go to the ribs. Now, if we think about the role of the ribs, it's surprisingly important in mobility of the whole thoracic spine. When, if we just think about breathing, we have joints between every vertebra. We have joints on the front side between the sternum and the rib. We have, of course, joint here behind between the vertebra and the rib, costotransverse and costovertebral joints. And all these joints should be moving while breathing. So we definitely have a very good, we should pay also attention to the ribs. Now, the other reason why ribs are very important is that they are very engaged as soon as we move the trunk. So, for example, a rib dysfunction and some tension in between two ribs can also have a big effect on range of motion, active range of motion in rotation, for example. So the way I would do my examination of the ribs, I would first get contact with the posterior angle of the rib. Now for first rib, it's a bit different. I would use a different hole, but now I will show you for rib 2 to 12. So for rib 2, I would start with the thenar part of my hands here, having a good position with my right leg behind, allowing me to use my body weights. And from here, I will do a little spring from posterior to anterior and check for the passive range of motion of every rib here. And for the lower ribs, I will go more into a caliper movement, as we have here in the upper limbs more a pump movement, pump handle, here bucket handle, and in the lower caliper movement. So caliper movement would be more in that direction. I can do this at both sides or at one side at the same time. Here for the lower ribs, lower ribs. Here, now I do my examination, I can notice some restriction in here. Here on the left, maybe the above here on my patient's right side, and again here, upper side on the left. So basically, this is the examination I would do for thoracic area, right? Now, let's say I've noticed a restriction into sideband here to that side. So that would be to my patient's left side. This would be restricted, right? So what I want to do is to have a gliding movement of the facet joint. What I want to have is a gliding this way on the left side and an opening on her right side to make the movement possible to the left side into a side bend here. I want to have a gliding of the facet joint. As you know, the direction of the facet joint is different in the lumbar, cervical, and thoracic spine, lumbar being more in this plane and thoracic being more in this plane. So basically I have my facet joint orienting this in this direction. So if I want to gain into side bend to the left, I will be standing on that side, so the side which will be opening, and I will try to induce some movement in this direction. So to make this possible, I will take contact with the hypothenar of my hand in the transverse process of the vertebra, which is restricted. Now I will have this contact, and I will make this direction of the force, I will change it according to the direction of the facet joint. So I don't want to be too straight here, because this would induce a lot of compression of the facet joint. I want to have a gliding, so I will be a little behind here. So check the position of the table according to that, and still make good contact here, good focus here. Now I will open this lever again from that side and have a gentle contact here on the shoulder of my patient to have a good control of the movement. So I will take my contact here and get a contact also with my leg pushing. So the movement from here is very light, and I do it with my body weight, with my leg pushing there, and then with my hand bringing here. So I have a good control of the patient and nice gentle movement here. Now with this hand, I make my technique more specific to this area I want to get mobility to. So I will induce first the movement with my leg here, and then I will make it more specific to this area. There. So I have an opening on the right side, and now a side bend to the left. I will release and come again to the starting position. And there. And just repeat this. This is basically a mobilization technique assisted with you making benefit of the movement and using my applicator hand to make it more specific to the area I want to get mobility to. There. So this is, to give you an example in which case I would use that, I could take an example of a tennis player I had a few weeks ago who had shoulder problem. And the shoulder problem was correlated with the tennis playing. So every time he would have to to do some overhead movements, then he would have pain in the shoulder. Now, if we think about the mobility of the shoulder itself, it's very wide. The glenohumeral joint is very mobile. Of course, the function of the shoulder girdle in general is very important, but also the mobility of the thoracic spine. So in this case, I would be very interested to see, do I have enough sideband mobility in the spine here? All right. So again, this works very well for mid-thoracic, and as soon as you have restriction into sideband on one side or the other, sometimes you have even bilateral restriction. This works very, very well. Now, if I notice that I have also tensions in the muscles, I can use the same movement, but change my focus, change my hold so that the technique won't be focused so much on the articular aspect, but more on the soft tissue. So in order to do that, I can just, instead of having the contact on my side, I can go to the opposite side. So I will go above the spine to the opposite side here. Table can be a bit higher because now I want to have the direction of the force is going perpendicularly and a little bit here pretty superficial. It shouldn't be too low here. So I can use that movement again to make it more efficient on the soft tissue techniques. Here, so again, I'm using the same movement, but my focus changes a little. Now, if we go to the thoracics, upper thoracic, the idea is basically pretty the same. Let's put the patient in neutral position, it's easier. Now, basically, as I showed you from the beginning here, I will have some sideband here. Now, I can use this as a mobilization technique. This is pretty light, right? So I'm having a fixation of the vertebra I want to move and then have some sideband, right? I can change my position, have a good hold on the hand, fixating on the upper thoracic and having some sideband here. This is pretty light, and in some cases it's nice, but if you want to have it a bit more force, you can use another hold, which will be that way. Table pretty low. And now let's imagine again I would have a restriction into sideband to the left. So the opening side, the side on the right with the facets moving that way, would be restricted in opening here. So I want to have a contact on that side. Now I want to have the table pretty low because I want to be able to come above my hands here. And with this hold, the direction of the force will again go into the direction of the upper thoracic facet. So basically the force will go from my thumb toward my ankle here. So having this position make it easier to get this force into this direction, right? If I'm a bit more too away, then my force will induce too much compression. So it's not so comfortable and then not so efficient here. So again, I will induce the movement with my leg here and make it more specific with my thumbs there. Here. This is one of my personal favorite technique, mainly because it's an area which is pretty stiff in many patients. Maybe because of our way to work, a lot of standing, a lot of sitting in the same position, and we need mobility in this area. Now, again, if I'm thinking about reason why I would be interested in this upper thoracic area, well, basically everything which is related, maybe above, below, or again, more distally on the side. So if I'm thinking about a patient with some cervical problems, I would definitely have examination and probably treatment of this area. Breathing also requires some movement of the upper thoracic, and as we are going to see in a moment, of the ribs too. Now again, every time I have a movement above my head, I need movement of my glenohumeral joint, of my shoulder blade, but also of my upper thoracic and thoracic spine. So definitely I would be interested in this area. There's some other reasons why, maybe if you think about innervation, sympathetic innervation of the upper limb, I would definitely also be interested in the upper spine. So for all these reasons, maybe may they be mechanical, or if you think about innervation, then it's a very, very nice area to work on. And a very nice way to have mobility here with the patient being able to relax. Now from here, as I showed you to work on how I can do my examination on the ribs. Now from here, see. Basically, we don't have that much restriction in this case, but to show you anymore, at least, to show you an example, maybe here a little. Now, I feel that here I have a restriction. So my force was going anterior, and I feel that, right, this is a bit stiff here. So next thing I'm interested in is that do I have a restriction which is on the spot, so no clear direction, or do I have a restriction maybe inferiorly, so it's not going inferiorly, or do I have a restriction superiorly here? So to check that, basically I will check for the space between the intercostal space, so the space between two ribs, here, here, here. And if I think that this rib is restricted, then I'll have a look at the space below and the space above. So first thing I want to know is which rib is restricted, and the second thing is that is there a direction in this restriction? Is it more superiorly or inferiorly? Now again, basically it's here, yeah. Here, so I check the space, and I notice that this is pretty actually smaller here superiorly than inferiorly. So my hole will be superior of the rib, because I want to bring it lower, inferiorly. So my hole will be inferior, and I will push inferior here. I can use the direction of the movement here into sideband, because we know that every time we have a movement into sideband, and we have movement on the ribs too. To make it a little bit easier, I will choose to start from this position. So I will go into sideband here, and from that position, I will go away. But to make it easier, in some cases, when you feel it's pretty restricted, it's good to start in the easier position here. So again, imagine you have the rib here. You take the hold superiorly of the rib here, so that you can induce a force going inferiorly here. Maybe one hand or two. I like to use two hands, and I have a good control of the table here with my leg. Now from here, I will ask my patient to breathe in deep. Good, and exhale. Right. Now, if I want to induce a force that is going inferiorly, I will use the exhalation of my patient. When my patient breathes out, I will push. When my patient breathes in, I will resist the movement, superior movement of the rib. So again, breathe in, now I resist. Breathe out, I will push down. And again, breathe in, and breathe out. Good. And at the same time, I will continue to do this, and at the same time that I start to feel some release and to gain some movement inferiorly, I will bring the upper body into sideband to the right. So this will make my force going inferiorly more efficient. So I have a fixation here, and I'm going into sideband to the opposite side. All right, so if my rib was restricted, and I notice that the space above it is limited compared to the space in below, which would be bigger, then I would induce a force going from this way to that way, so that would be inferior here. Now I can do the opposite exactly. If I would notice that I have a rib which is restricted superiorly, let's take from this other side here, I can feel that there's a rib here restricted, here, and let's say that actually it is actually a little restricted here. The space below the rib is a little smaller than the space above the rib. And if I would ask my patient to breathe in deep and out, probably what I would feel and what I can notice now is that the movement during breathing, when my patient breathes in, the rib doesn't really come up, right? So it's inferiorly and it's restricted, so it doesn't really move superiorly. So what I would do, again, I would take a contact now below the rib, and I would induce a force going superiorly, and I will get benefit of the inspiration of my patient, asking my patient to breathe in deeply, right? So can you breathe in deep, and I'm pushing, and breathe out, and now I just resist. So the principle is when the rib is moving superiorly, I kind of emphasize the movement superiorly. So it's restricted, so I kind of push. It's a direct technique. I go against the restriction. Breathe in, and when she breathes out, I resist. Again, I can make this more efficient using this side bend. So every time I can feel that I can go further into bringing the rib superiorly, I will also induce some side bend here. Right. Good. And of course, after that, once we've done this technique, we check again the mobility of the ribs and movement during respiration. Right? So my examination was passive here for the mobility of the ribs. Second thing is check for the intercostal space above and below the restricted rib. And then third thing, ask for confirmation. Ask your patient to breathe in and breathe out and notice the movement of the rib. Again, you might have a restriction in all directions. So it's not related to inhalation or exhalation. It's just restricted in both directions. So then you can use just mobilization of that rib. All right. So we've gone through thoracic spine, upper thoracic, examination, mobilization into side band, soft tissue here in this middle thoracic area. Then we've done mobility here, mobilization of the upper thoracic into side band, and then the ribs. Let me think. Next, we'll go through middle thoracic into flexion and extension. So for this technique, I like to have the table a bit higher, and I will hold here from that part of the table. I will show you from that side here, you have a lever here that you can open. I will open it from the other side. It's more comfortable for me here. And basically now the movement I have is flexion and extension of the thoracic spine here. Mid-thoracic here. So basically this works the best for T5 to T8. After that, T9, T10, 11, most of the time you still have extension. So I will more use maybe this flexion. But for extension, the mid-thoracic, it works very well. So for this technique, I can basically have my focus again on soft tissue here. So table will be a bit higher, and I will be a bit lower on my stand. Hold here, and what you want to have is a stretch. So I'm having fixation with my hand and bringing the spine into flexion. So basically what I have is a stretch of these muscles. Here. I'll show you from the other side. So hold here. I have a large hold. I'm pretty on the surface. I'm not pushing or bringing compression into the spine. I'm more having a stretch here. Now, to make it more efficient into the stretch, what I can add now is side bend. So I will go now into flexion and from here into side bend. So I can combine these directions together. We'll hold here, go down, and into side bend. Release the hold, come back, have a fixation here with the hand, gentle slide and stretch, and then into side bend here. So I show you on the other side. Here. Now my focus, of course, is on soft tissue. Of course, you have now movement of the other structures as well at the same time. Here. Right, now another way to use this function here is to have extension mobilization. Now if I notice that I have a restriction in the middle part of the thoracic spine, for example, here. And now this could be one side more than the other. It's basically both sides. Now, what I will do is open both. I will go down in a circumduction pattern and come back to neutral. So go there and come back to neutral. I don't really want to go into extension. It will be enough, usually, if I come back to neutral, if I'm specific enough with my hold. So let's say I want to have more extension in this area. And let's say it would be more on her right side. So I would basically have a contact here on her right side. And I would go first away here, come back, come into extension, or into extension, but up to neutral position. And at the same time, I'm pushing here a little here into extension. Again, I don't want to go too far into extension for two reasons. Now I have the erector spinae muscles tensing, and also I have the facet joint closing. So it's not the best way to have mobilization into extension. I've noticed that coming from flexion toward neutral, up to neutral, is more comfortable for the patient. So it's basically more efficient because the patient is more able to relax. There. Now I like to use this circumduction movement. Of course, you don't have to. You could use only flexion and extension. In this case, this could be closed here. But personally, I've noticed that it makes it a bit more comfortable here to go away and come back. And here. Now these are some examples of things I can use to have mobilization techniques on the mid-thoracic. Some things I'd like to show you about the comfort of the patient is that usually I like to think about the patient positioning also during these techniques. Now, if I'm working on this upper thoracic, I might have a little of flexion here in the lumbar spine, here, to make it a bit more comfortable for the patient. But one thing that I think it's very good to consider is as soon as you're working on the upper thoracic and you're having a force in the direction of the facet joint here, then I think it's it's a lot more comfortable to have a little of flexion of the cervical spine, or at least not into exactly neutral position. The reason is that even if my table is low and I press in the right direction, I still might get some compression here on the cervical spine, and it's not so comfortable. So if it's not so comfortable, the patient maybe won't relax so much, and then you might not get the effect you want. So a little of flexion, maybe I could even get a bit more here. When you're working on the upper thoracic, makes it more comfortable for the patient. Yeah. Right, and one last thing I wanted to show you about some possibilities I have here on the ribs and thoracic spine area would be using, again, this lateral movement of the thoracic spine here, having, again, a good control here so that I can use my hands, but still I have a good control with my body, control of the movement of the patient. Now, let's take a bit of flexion here. So I'm bringing the spine into flexion, closing here, the sideband is still open. And now I can induce this rhythmic oscillating movement with my body and emphasize the movement on the ribs with my hands here. So the techniques we've seen on the ribs were a bit more specific into one direction and one rib. Now, if you notice that you have an area which is pretty restricted, and you feel restriction on both sides, or at least on one side, but several ribs, then you might consider also this kind of technique where you have a little more global movement here. So if I show you with one hand, I'm bringing into sideband and I press gently on the posterior angle of the ribs and then release. And then press and then release. Now, if I'm working on the other side, it will be press when you go into side bend and release. Press and release. And if you notice that you have on both sides a restriction, then you can just go from one side to the other. As you know, you also have a very important role from the autonomic innervation on the thoracic spine. And this is also something you might consider if you have a lot of tension in this area, or a patient with a lot of stress and a lot of restriction in there. Also to work on the ribs here. Working on the ribs will also have an effect on the sympathetic innervation here. Now this is pretty soft, and it's something you can finish with when you've been working on this area. Here. Now these are some things we were thinking to show you, mostly on the thoracic spine. Of course, it's very important to consider the other areas of the body. If you had troubles maybe in this area, still consider the lower spine, of course, and the thoracic spine, and the cervical spine, and the shoulder girdle. We have big muscle groups that have an influence on larger areas. One I would consider, if I have restrictions in here, I would also think about, for example, latissimus dorsi, which is basically a mobilizer muscle for the upper limb. But if you think about its large area, it does have an effect on the ribs, on the shoulder blade, but also as far as the thoracolumbar fascia goes, as far as the pelvis also. So these are things I would also consider. If you have some ideas or things you would us to show you, of course, we are very glad to hear about this. Did we have some questions in the chat?
Well, we got some questions, and I think I had some answers already sent to the questions, and there were some ideas on the future. They asked about the drop technique, for instance, and so on. And
right.
I answered that I think this is something like, for instance, the whole lumbar and sacrum area is a part of the body that is a topic for different webinar completely. But for now, I think you've done a great job, because there weren't too many questions regarding the thoracic spine and ribs area. And for now, I think we're done for today. And please give us feedback and give us ideas on future topics, what parts of body you want to learn more of, and different techniques and so on. And I want to thank Kevin, you, and our model here for staying patiently on the table. And please join us again on our next webinar, and have a good day or good night or good morning wherever you are. Thank you.
Thank you.